Everything is good.
Should I tell them?
Good afternoon, everyone. Okay, good afternoon, everyone. Good afternoon, and thank you all for joining today. It's a pleasure to welcome you to this very important conversation, investing in health in a limited fiscal space, hosted by the Nigeria Health Watch, Premium Times, and the Punch newspaper. My name is Adenike Adebowale Tambe. I'm the head of the Health and Development Desk at Premium Times, and I'll be moderating today's really important event. As we all know, Nigeria's health system is undergoing a defining moment where the push for universal health coverage must meet the reality of limited resources. For years, the country has worked towards ensuring that every Nigerian can access quality healthcare without financial hardship. Yet, the number tells a different story. Out of pocket spending still accounts for about 75% of all health expenditure, one of the highest rates in the world. This means that many families still bear the cost of illness alone. Also, at the same time, foreign aid and donor funding are declining, especially following the changes in US global health priorities. Now we're left with fewer external resources and growing domestic demands. Nigeria faces a pressing question. How did we, how can we sustain and expand health investments in such limited fiscal space? It's in the response to this reality that the government launched the Nigerian Health Sector Renewal Investment Initiative, a reform framework designed to align resources, improve coordination, and ensure value for money across the health sector. A key pillar of this effort is the sector-wide approach, or SWAP, which brings all partners, governments, donors, and private sectors actors under a unified investment framework for health. Building on these reforms, the National Health Financing Dialogue held recently brought together policymakers, development partners, and civil society to explore sustainable financing strategies and strengthen accountability. One of the government's commitments from that dialogue was to enroll 44 million Nigerians into health insurance by 2030. This is up from fewer than 20 million today. It is an ambitious target that reflects both the urgency and the opportunity of this moment. And that's exactly what today's conversation is about. How can Nigeria mobilize and sustain health investments despite fiscal constraints? What reforms are needed to make every naira count? And how governments, the private sector, civil society organization, and the media can work together to build a more resilient, self-reliant health system. We're privileged to have really distinguished experts here today to speak on this topic and unpack these issues and also share practical perspective. But before we begin, a quick talk about the convener of this very important discussion. I'll start with the Nigerian Health Watch. The Nigerian Health Watch is a division of the Health Watch Foundation, a leading non-profit organization dedicated to advancing health outcome in Nigeria. The organization combines deep expertise in health and strategic communications to drive evidence-based advocacy, strengthen the capacity of health sector institutions, and influence policy for impact. Also, Premium Times is a Nigerian online newspaper recognized for its investigative reporting and in-depth analysis on governance, human rights, and socio-economic issues. It also operates the Center for Journalism, Innovation and Development, which promotes data-driven journalism and media innovation across Africa. This event is also done in partnership with the Punch Nigeria Limited, publishers of Nigeria's most widely read newspaper, which has remained a steadfast pillar in the nation's democratic and developmental journey for over 5 decades now. The organization is committed to leveraging the power of the media to enhance the quality of life aspired to and lived by every individual by promoting and defending the values of democracy, truth, inclusiveness, and free. Please, can you hear me now? I had a little trouble with the internet. Sorry about that. Yes, okay. Thank you so much for confirming that. I was talking about Dr. Maurice Atoki. Permit me to start again, please. So we have Dr. Maurice Atoki here, the Chief Executive Officer of the African Business Coalition for Health, a coalition of African business leaders working with governments and other stakeholders to strengthen the continent's health sector. She also facilitates the Health Policy Commission at the Nigeria Economic Summit Group and is an alumna of the Harvard Business School London Business School and the Yale University. Dr. Atoki's career spans both public and private sector, and she's deeply passionate about sustainable development, youth empowerment, and leadership in Africa's health space. Thank you. And next, we're joined by Mr. Felix Abrahams Obi, a health systems and financing expert with over 2 decades of experience advancing health, governance, and education outcomes. He serves as the Senior Program Director and Country Director for Results for Development, where he oversees the organization's Nigerian portfolio covering health, nutrition, and governance initiatives. Mr. Obi has worked extensively with government and development partners to strengthen health financing and promote evidence-driven policy reforms. And finally, permit me to introduce Dr. Bill Bailey Davidson, who leads the Strengthening Healthcare Systems program and serves as the administrative lead at Budgets. Budgets is a civic organization leveraging technology to promote transparency and citizen engagement in governance. She's also a medical doctor with over 10 years of experience spanning clinical practice, international development organizations, and the United Nations system. Dr. Davidson's work focuses on public health, program management, and global mental health, and she remains passionate about youth development and community engagement in fostering accountability within the health sector. Thank you all so much for listening, and thank you to our experts for joining today. Welcome to this very, very important conversation again. So I'd like to commence our partner discussion immediately. I'd like to begin with Mr. Felix Obi, just confirming that he's on the call, please.
Oh, yes, I'm here. Thank you.
Okay, welcome, Mr. Felix, and thank you for joining today. So I'm going to start this panel discussion with you.
Oh,
Okay,
apologies.
welcome,
I
sir.
think my camera is not showing for some reason, but no problems.
Oh, okay, that's okay, but we can hear you clearly. That's fine.
Okay, great.
Okay, sir, thank you so much. So the first question, Nigeria has made several ambitious commitments through the Nigerian Health Sector Renewal Investments Initiative and the sector-wide approach compact. From your perspective, how can these frameworks realistically improve the efficiency and impact of health spending, given the current fiscal pressures?
Yeah, thanks, Nike. And so for a long time, Nigeria, our health financing, especially, was not so organized. So first of all, we had the first health financing national policy and strategy in 2016, which was the first attempt to try to have like a cohesive policy framework for financing health in Nigeria. And of course, like you know, for most Nigerian policies, we don't necessarily implement with fidelity, like making sure that we implement the way it is written in the policy. So having that compact was one of the first times that donors and the government came to like align in a way that we are going to pull resources together to implement our health programs. And one of the advantages this compact has is that for instance, this compact was signed December 12th of 2023, like you know, and we had governors agreeing to the compact. They signed off. Nigerian Governors Forum signed on behalf of governors, and we also had the donor partners signing. So that was more like the first time in a long period of our history that government and partners were coming together to agree to have one plan, to have one budget, and also in terms of speaking together and having one monitoring and evaluation framework. So it has a lot of potential, and to a large extent, I think Nigeria has experienced an opportunity for donors to work closely together. I have worked in a donor agency in the past, and I'm also from the development sector. Most times, donors pick an area of interest that aligns with maybe the foreign policy of their government, and then they run with it. It may not necessarily speak to the priorities or the needs of Nigerian health sector, but they will run with it. So this is the first time that this such is happening. And for those who don't know what this sector-wide approach is a way of improving the coordination and governance of the health sector such that we are all aligned in terms of priorities and also the financing. So within the Nigerian donor community, we have what we call the Development Partners Group for Health. And this Development Partners Group for Health is made up of all the key donors, both bilateral and multilateral donors, including the UN system. And they have a platform where they meet previously, but the minister and his team engage them very closely for them to align with the vision of the swap. And some of the things they did was to even map their own resource landscape. They did that, and then to see where is everybody implementing, what are people investing in terms of health programs. We have what we call the 6 pillars of the health system. So which programs are focusing on strengthening leadership and governance, which ones are focused on service delivery, which ones are related to improving the data or human resources for health, research, or health information management system, or broadly around health financing, because there are some technical work or even investments in health financing. So for me, I think it's a great opportunity for Nigeria to mobilize more resources for the health sector, as well as ensuring that we are efficiently using the resources to provide the health services that our people need. Maybe I'll just stop here for now.
Thank you so much, Dr. Felix, for that very elaborate response. For setting the tone and breaking down these critical policies and financing issues. You also reiterated the importance of implementations to ensure that everything contained in the framework actually being implemented and achieve its desired result. Thank you so much for that. So this leads me to our second panelist for the day, Dr. Maurice Atoke. Please confirm you can hear me well.
Yes, I can hear you, Madam Moderator. I hope you can hear me too.
Yes, Ma, clearly. Thank you so much for joining us today. Okay, welcome. So just go straight to the question. I want to focus on private sector with you. The private sector is often described as an untapped partner in health financing. In a constrained fiscal space, I'll go again. The private sector is often described as an untapped partner in health financing. In a constrained fiscal space, what practical roles can businesses play beyond philanthropy to strengthen Nigeria's health system and drive investment?
Right, thank you so much for that question, and good afternoon, everyone. Thank you for having me on this panel and in this session. So let me start by saying that the reality of our strong fiscal space at a national level and at a regional level, so when I say region, I mean the continent, really compels us to think beyond traditional aid, government budget, and philanthropy, to view health not merely as a social good, but as a strategic economic sector that merits deliberate investment. And so when we say deliberate investment, there are three core areas where businesses can practically strengthen Nigeria's health system beyond the corporate social responsibility that, we traditionally are used to. And this will help to drive sustainable investment impact. First and foremost, it's clearly innovative financing and pooled investment mechanisms. So businesses can mobilize new financing streams by investing in blended finance vehicles, in health bonds, and impact investment funds that de-risk health ventures for both private and public investors. So for instance, corporate health funds can be structured to co-finance priority interventions. So think about local manufacturing, think about diagnostics, the digital health infrastructure, alongside government and development partners. Another area we want to think about is efficiency gains through private sector expertise. So the private sector brings strong capabilities and competencies across board. So the one that we can easily think about as far as the health value chain is concerned is supply chain management. You will know private sector to be result oriented. So when we talk about supply chain, it goes into the crux of the business to ensure that it succeeds. These are areas that can influence, the health sector as well. So let's again think about things, areas of digitalization, things about data analytics, logistics optimization, and financial governance. These are areas that can improve the efficiency of health spending when it is effectively, put together from the onset. In constrained fiscal conditions like ours, efficiency is as crucial as funding. So PPPs, PPIs, public-private partnerships, or private investments that leverage private innovation for health system digitization, pharmaceutical distribution, and predictive data management can yield long-term savings and better health outcomes per naira spent. And the third is market development and local production, which is largely important and becoming more and more pivotal to our health system strengthening, to the growth of the entire continent in terms of health. So beyond financing, businesses have the capability to build local production ecosystems for medicines, for consumables that are ours, and even R&D and medical technology. This creates jobs, it reduces import dependency, and it improves the availability of essential products. This is the one thing that Africa needs to get right, at this dispensation of digitalization. By investing in local manufacturing, research, and technology transfer, private firms can help create self-sustaining value chains that is cross-beneficial and that strengthens national health security and stabilizes health costs over time. The one that encompasses the three is ensuring a viable policy environment. For the private sector to thrive and to play in this catalytic role, the government must ensure predictable regulations, it must ensure fiscal incentives and transparent procurement frameworks that make health a viable investment frontier, recognizing that we are all critical stakeholders, from governments to private sector, to the academia, to civil society, and the world at large. Thinking about the fact that we're now a global village. I mean, COVID, if you didn't teach us anything, it taught us that. The real opportunity lies in co-investment, in co-creation, and in co-governance, where businesses, where governments and civil society, as well as academia, work together to make every naira spent on health count twice, one for public good and the second one for economic growth. Thank you very much.
Thank you so much, Dr. Atoke, for speaking on the energy and the efforts the private sector can actually put in to ensure Nigeria achieve its health financing target. And he also spoke about the importance of local manufacturing and partnership with the private sector. I believe that we all know that local manufacturing can go a long way in ensuring that the country actually achieves its health targets. Because like you mentioned in your speech, majority of the drugs we take in Nigeria are being imported. And I mean, these are some of the things we can do on our own. Some health experts have repeatedly reiterated the importance of this, the importance of local production of drugs, including drugs for diabetes, hypertension, and all of that. I mean, we don't really have to rely on donors to get this maybe easy, would I say easy things done. Thank you so much, Dr. Atoke. And this leads me to my next question for Dr. Biobele Davidson. Please, can you confirm you can hear me, ma'am? Dr. Davidson, are you with us? Oh, okay. I think she just left the call. So Dr. Felix Obi, I'm back to you, sir. Are you with us?
Yeah, I'm here. Apologies. I don't know why the camera is not showing, but I'll try and see what we can do to sort it out.
Okay, that's okay. So before I get to you, please, I would like everyone, in case you have any questions to ask any of our panelists, kindly drop it in the chat box. I'll pick it from there. There will also be about 10 to 15 minutes to ask some further questions if need be. Thank you all so much for staying with us on this call. So to my questions to Dr. Obi, following the 2025 National Health Financing Dialogue, the recently concluded one, I think about a month ago, what early lessons are emerging that should inform state level implementation? And how do
I
you think
can't really hear.
civil... Okay,
Is the network is breaking? In case
okay,
you're speaking, I can't really hear what you're saying. I don't know if it's
okay.
from my
Is it from
side.
my end? Okay, I'll go again. Can you hear me clearly now? Okay. I don't know if it's my network or yours. Can any other person hear me, please? So I'm sure it's
I can hear
how
you. I
to
think it's
address.
Dr. Obi's network.
Okay, thank you so much. Dr. Obi, I think it's your network. I'll give you a minute. Okay, while we wait for Dr. Obi to resort the network issue, can I come back to you? Oh, okay. Please, I just got information that Dr. Davison is back, so I'll come back to Dr. Obi and Dr. Atoki's son. Dr. Davison, please, can you confirm you're on this call and can you hear me?
Yes. Let me just turn on my video briefly. Yes. Hi. Can you see me?
Not yet.
Hi. Can you hear me?
But I can
I
hear
can
you
see
clearly,
you and
so
I
that's
can
fine.
hear you. You need
Oh, okay.
to use your arrow. We can see her and we can hear her.
Oh, okay, yes. I see you. Thank you so much for joining today. Thank you.
Thank you.
So we started this
Please permit me
discussion
to kindly
already. Go ahead.
kindly permit me to turn off my video because I'm actually at an event and but I could actually contribute.
Okay, that's okay. Thank you so much, Dr. Davidson. So I'll go ahead and ask you the next question. We started the discussion already on health financing and its importance, the importance of domestic financing for the country. So for Budgets Nigeria, Budget has long advocated for greater accountability in public spending. What are the biggest transparency gaps you see in Nigerians' health budget? And how can digital tools or citizen engagement close those gaps?
Sorry, just could you just give me a few minutes to just set up my audio because of the background noise, and then
That's
I could go
okay.
back on the question. Thank you. I'll notify you when I'm ready.
Oh, okay. So we'll just go ahead. Okay, Dr. Obi, can you hear me now?
Yes, I can. Thank you.
Okay, thank you so much and welcome back, sir.
Yeah.
Okay, so I was asking, following the 2025 National Health Financing Dialogue, what early lessons
Yeah.
are emerging that should inform state-level implementation? And how can civil society and the media help track these commitments to ensure that the declarations made are actually translated into better health outcomes for Nigerians? We don't want it to be one of those dialogues we have every year and there's no result for it. So how do you think this can actually translate into better health outcomes for the country and its people?
Thank you so much. So building on the initial conversation about swap, so for the first time, especially starting from last year, the Ministry of Health started the plan for all states to develop annual operational plans.
Mm-hmm.
So the idea is that for your budget, so maybe this will also connect to the budget conversation later. So all states should develop annual operational plans called AOPs. And the AOPs are supposed to be like clear strategic plan that speaks to how each state is going to address the healthcare needs in their state, whether it is infrastructure or service delivery across all the priority areas. So they're supposed to have clear plans that shows what they want to do, how they want to do it, and then the resource requirements. So if we have the plans and the budget kind of speaking to each other and aligning, then it makes it easier for civil society or the media to track. So you look at the health budget, for instance. Budget usually does analysis of the budget each year, whether it's the draft or the appropriation act. You will see that a lot of times there are a lot of redundancies, a lot of areas that money is being channeled to that does not speak to the priorities of the health sector. So I think it's important for citizens to have access to what the plans are, what the government is planning to do, both at the federal level and at the state level each year, so that when people are engaging in the budget process, they understand what the components are, what the government is planning to spend for health sector, what the allocation picture looks like before it is even passed into law. So what I notice is that we don't have so much engagement during the budget formulation process. So citizens don't make so much input, or the media, but we only get to know maybe when it gets to the National Assembly or the State House of Assembly for deliberation and all. So in a sense, if citizens are involved in the early stages of maybe when the AOPs are being developed, when the budget is being drafted, so that people are keeping an eye on what is coming for the health sector that year. And then when the budget is passed into law, become an appropriation act signed by the president, they can actually also track quarterly the resources being released for those programs or interventions that are included in the budget, for instance. And then at the end of the year, we want to know to what extent did our budget perform? Did we achieve those things we said we are going to achieve? Did we invest the right resources in the areas that are of priority needs, the priority needs of our people? So the media and CSOs have a role, a major role to play. And I can see that both the Punch, Premium Times, and all the media folks here, I think it's important to work closely with even people who are within the government to get this data about what the government plans to do, and then ensure that citizens have access to that. I know that the Budget Office of the Federation used to provide information, what they call like the citizens, like a citizens version of the budget. So they have it on their website, where each year, even the fiscal policy paper, the MTF, they have them there on their website. But a lot of times citizens don't know what those documents are. So I think it's important that the media and CSOs help to provide this information to our people if the government, like Ministry of Health and the agencies, are not doing that. So it is the onus is on us as citizens, led by CSOs and media, to provide that information and also help facilitate the issue of transparency and accountability functions of the citizens. Thank you.
Thank you so much, Dr. Obi, for that very elaborate response. Thank you so much. I'm glad you mentioned that aside budgets and any other organization that actually gives a breakdown of the budget, media journalists should also push, like go to the Ministry of Health or get information. But I must also say that when you request certain information from the Ministry of Health or the Budget Office and all of that, you may not get it. You may most likely not get it. And this actually gives room for journalists to push for that. I think this is where investigative journalism actually comes in, because we cannot keep taking whatever they give to us. I mean, they'll give us data, statistics, anything they want us to say. But as journalists or civil society organizations that prioritizes health and health financing, it is still important for us to dig deeper. I mean, I think recently there was a particular figure about 32 billion naira. I'm not very sure that was released from the Basic Healthcare Provision Fund and all of that. Majority of journalists, or some journalists, will just take that information and just like, okay, just run with it. But is it actually true? And if yes, if this a particular amount is actually disbursed, to which community, which PHCs in the country got this? Are they used as they should be? Are they getting to the people that actually need it, which is mostly persons in the rural community? So are they getting the investments? Are they getting the money? It's not just the figure going around the news and all of that, that they are disbursing certain amount of money, the Basic Healthcare Provision Fund. Are PHCs actually improving in the country? So thank you so much, Dr. Obi, for throwing light on that. So I'll go back to, I think Dr. Davison is ready for us. But before then, please, Dr. Davison, can you give us a minute? I'd like to ask Dr. Atoki to build on our previous response about partnership with the private sector and the Nigerian government. Dr. Atoki, can you confirm you
Yes, I
can
can hear
still
you.
hear
Can you
me?
hear me and can you see me?
Yes, I can hear you and I can see you. Thank you
Okay.
so much. Okay, so are there specific partnership models or incentives that have worked in other sectors that could be replicated in the health sector?
Right, thanks a lot for that question. So, and I like that the thoughtfulness behind that question, because what we represent as a private sector coalition is the capacity to bring together multiple stakeholders across the private sector, especially at leadership level, to rethink, how we can push and support health. So, let's think about some of the popular sectors in Nigeria. So let's use Nigeria as a case study. Maybe agriculture, energy, and of course, fintech that seems to be recently booming. These are sectors that can effectively be adapted to strengthen our health systems and mobilize private capital for health. It's been done there. And there's no reason why we cannot, begin to simulate our thoughts towards how we can also be impactful on health. So let's think about three examples, particularly relevant to Nigeria's health financing landscape. It's blended finance and co-investment platforms, really known to have worked in the agriculture and infrastructure space. So in sectors like agric, for instance, where we've seen our blended finance instruments, where concessional funding from government or development partners is used to de-risk private capital and have unlocked large-scale investments. So this same model can be applied to health by creating health-focused co-investment platforms that combine grants, impact capital, and commercial funds. We can crowd in private investors. We can to finance local manufacturing, to finance logistics, and to finance diagnostics, as well as digital health innovation. We are already exploring such models through our coalitions, to align private sector participation with national health priorities in ABC Health. And we're supporting private sector's viewpoints in terms of advocacy to be able to achieve this. The second example, the second one kind of model will be performance-based contracting model and notorious public-private partnerships that have been successfully implemented in energy and utility sector. So the energy sector has successfully implemented performance-based PPPs, where service providers are rewarded for measurable outcomes, such as improved coverage or cost efficiency. So applying this to health is not rocket science. We can structure outcome-based contracts for essential service delivery, where private operators are paid based on health indicators achieved. So for example, immunization coverage, facility, uptime, digital data reporting, and so on and so forth. And sometimes we'll say this exists already, but you see, we don't see the traction because it's not embraced. This incentivizes efficiency. If we have the right size of public-private partnership parallel to the gaps that we have in health systems, this will make us move as far as strengthen health systems in Africa and in Nigeria is concerned. So we must believe that performance-based contracting and public-private partnerships incentivizes efficiency, it incentivizes innovation, and it promotes accountability in all of these sectors, inclusive of health. Now, the third one is to think about innovation hubs and regulatory sandboxes. These ones are popular in the fintech and ICT model. The fintech sector's regulatory sandbox approach, where innovators test solutions under flexible and supervised environments. We've seen it to accelerate innovation and investment. So health itself can adopt similar models through health tech innovation, hubs that allow startups and private enterprises to pilot scalable solutions in areas such as telemedicine, in data management, and supply chain automation. When this initiatives come about, especially when they approach the ministries of health, they should be embraced and not saddled with so many requirements and things that will discourage them. And finally, it's the enabling environment. And I talk about the Ministry of Health, particularly as the apex area where all of these health solutions are being controlled. The enabling environment is critical. So beyond even really making sure that there's access, then we must think about incentives. Incentives such as tax credits for workplace health programs, investment guarantees for local manufacturers, and public procurement preferences for locally produced goods can make the health sector more attractive to private capital. Without all of this, we're only just really going in circles. I leave it at that. Over to you, Madam Moderator.
Thank you so much, Dr. Atoki, for that very elaborate response. Thank you so much. So I'll just go straight to Dr. Biobele Davidson.
Yes, please.
Okay, thank you so much for joining us, ma'am. So I'm going to your first question now. Budget has long advocated for greater accountability in public spending. What are the biggest transparency gaps that you see in Nigeria's health budgets? And how can digital tools and citizen engagements close those gaps?
Thank you very much, Nike. So it's a pleasure being on this call. And I will be speaking because I'm passionate about what we do, especially when it comes to citizen accountability. Please kindly confirm if you can hear me.
Yes, clearly, please.
Awesome. Awesome. Thank you very much. So we all know that just leveraging on what Dr. Felix had earlier said, Budget itself is a digital tech organization that actually bridges the gap between the government and the citizens. And for over a decade, we've been involved, especially at the forefront, in promoting transparency and accountability, looking in context the Nigerian budget system and also the fiscal spending space itself. Now, we all know that accountability and transparency has been a major issue in the long run over the past years. And the only way we could look at having an effective mechanism is having the citizens in the system itself. So one of the key gaps that we've seen over the course of the implementation is the budget itself. We can look at the budget of, let's look at the budget of 2024 itself. Across the nation, the 36 states had budgeted 1.32 trillion naira for health, but only 816.64 billion was spent. And that gave us a performance rate, especially at the budget level, for 61.9%. It means that when there are these gaps, citizens find it very difficult to trace how much funds were actually allocated and when they were disbursed and how these funds were actually utilized at the facility level. And that also brought an attention to the figure, the 32 billion you had raised in the red letter itself. Because the facilities were not clearly stated, we do not know what facilities these monies were disbursed to. And actually, we're in communication with the Ministry of Health to have that released, for which they had acknowledged. The next point we're also looking at is weak disclosure and delay in reporting. So if you look at Nigerians' scoring system, especially in the last International Budget Planning Open Budget Survey, we had 31 out of 100 for transparency, 19 out of 100 for public participation. Budget itself has been at the forefront in terms of engagement to ensure that there's timely release, and then these releases are properly detailed. Now we're also looking at line items themselves, looking at the health budget itself. You'll find out that some line items are not clearly stated itself. So at that point, it begins to bring about credibility issue, for which budget itself is looking at how do we clearly state each line item to ensure that the concerns that the line items, the items that are allocated for those line items are clearly stated out. Now let's bring it down to the facility level. We had actually launched our PHC tracker itself, and we found out that at the community level, there was little to no participation across a lot of the PHCs where we were implementing at the facility level. Community members were not involved in the system. They felt like these facilities belong to the government itself, without having that notion that the PHC is actually for the community and is utilized by the community. and should have participation from the community themselves. So when we launched our PHC tracker, we found out that communities had little to no awareness. Even when they had little to no awareness, there was this loss or distrust in the healthcare system that did not allow them to effectively participate in the healthcare system. Now, with that, it shows that a lot of persons would not even be involved in the budgetary part of the system. If they were not actually, if there's that mistrust in the service delivery aspect of it, then there's also going to be that part of it that has that gap in terms of budgetary participation, especially now looking at these BHCPF facilities. And then lastly, we're also seeing that there's been some gaps when it comes to poor linkage between expenditure and outcomes. So even when allocations are made, that link that actually gives us the pictorial view between the actual spending and the actual health outcome. For example, Dr. Felix had mentioned drug deliveries, PHC infrastructure, and you see, because there's that gap, there's that opacity itself. People are people are people are unable to have that effective tracking. So what are some of the digital tools that people could use to bridge this gap? One, it's the open data portal. So using the open data portal, people can be able to go at these tracking portals, especially the OGIP portals, to see what is being expended, what is being allocated, how this money is being utilized. The next form is actually our PHC tracker. So Budget has a PHC tracker called www.phctracker.org that actually captures PHCs at the community level, looking at the state of the infrastructure, looking at the services that are being offered. And then this portal has actually started, which started in 2022 across 75 facilities, have moved on to 200 facilities across the nation. So that's it from me. I'll just take a breather and we'll have the conversations continue.
Okay. Thank you so much, Dr. Davison, for that very elaborate response. Thank you. And thank you for mentioning the Basic Healthcare Provision Fund. So just still stay with me, please. So I'll head to the next question with you on Basic Healthcare Provision Fund. Before you joined, I'm not sure if you heard, I mentioned the 32 billion that was recently disbursed to primary healthcare center, part of the Basic Healthcare Provision Fund. So in your view, as the Basic Healthcare Provision Fund lives up to its promise in terms of accountability and impact. I'm asking this because before the 32 billion news, the red alert news tells all over the news, recently, we've heard other figures like billions of naira that have actually been dispersed through the primary healthcare provision fund channels. But we are seeing little or no impact. I can speak for Premium Times. We've done some investigative reports on PHCs in different states, and there's usually nothing to write them about, from poor infrastructure to shortage of workers, lack of equipment, just little things you should see in every health facilities. They are lacking in majority of the health facilities visited. And some of the PHCs that have actually been marked for revitalization are also being abandoned. Some are started and abandoned, and there are still some that no work has been done on and all of that. So do you actually think this fund lived up to its promise in terms of accountability and impact? Please go ahead.
Thank you very much. I'll start with saying that the release of the red letter a couple of days ago was a major move by the Ministry of Health in ensuring that accountability and transparency. And it's a commendable move from Professor Ali Pate to ensure that this is achieved. Sorry, can you hear me? Apologies that the background is noisy. So
it's okay.
The point in question of how evidence and open data can ensure health financing, especially when it comes to BHCPL, is one. It's ensuring that, sorry, I know there's a background noise. Some persons just got out of the room, but kindly just bear with me. It's ensuring that these allocations are open and they're also trackable. Yes, they're actually open, they're transparent, and they're trackable. And that's where we also comment, like I had earlier said, commending the Ministry of Health for releasing the red letter itself, because that gives us an avenue to say, okay, this is the amount of money that has been allocated for the BHCPF. But then the question now is, where are these monies going to? What facilities are these monies being allocated to? That is also something that we need to know, because part of budget's work it's been doing around the primary healthcare is also looking at healthcare financing. And we cannot have healthcare financing if, one, these allocations are not open. We do not know what facilities are coming in. We don't know what facilities these monies are going to and what amount of monies have been disbursed to each of these facilities. Now, secondly, we also need to ensure that the CSOs, the citizens, are actually involved in this tracking process. Dr. Felix had mentioned the AOP itself. He had also mentioned that this is the annual operating plan, that is a joint document that is being developed across these facilities. So that process itself has key stakeholders. It has the facility in charge, it has the WDC chairman, it has community members involved in the process of that. Now, secondly, we also need to be able to link this frontline service delivery, frontline facilities and service deliveries. And what do I mean by that? By ensuring that these packages that are getting across to them, did they improve the service? Because the goal of supporting most of these facilities with this fund is what? Service delivery. And what does service delivery translate to? What is the impact?
Dr. Davison, I can hear you.
In terms of the service outcome. Now, the other portion, budget credibility and performance. When Dr. Nike was, I think, please permit me if I'm wrong, because I'm just trying to also, when Dr. Nike was speaking earlier, she was looking at
Dr. Atoki.
I'm sorry, Dr. Atoki, rather. She was speaking about performance itself, looking at what we have done with the nutritional service, looking at what the Gates Foundation is doing, looking at what we're doing with immunization. Could we also have something like that actually measures performance metrics, to be able to say, look, this is this state which is performing at this point. This is what was allocated to them. Now, what does this performance do? It begins to enable us to be proactive in identifying bottlenecks that will affect the allocation, the release, the utilization, and lastly, the service delivery, which will most likely impact on the health outcomes themselves. Now, for us to be able to effectively track outcomes, especially when it comes to service delivery, the data must go beyond and translate into trackable service outcomes. Now, the last part of it is also enabling. I'm sorry, can you hear me? I'm so sorry.
Yes, it's okay. It's okay.
I'm sorry, I was at the women convention and I was supposed to give a presentation, so I was asked to stay behind for a bit, but just can you bear with me? So the last point is enabling citizens and communities to actively participate, and that's what budget has done under the SHS team, that's the Strengthening Health System, where we've actually implemented 2 projects called the SKIP, Strengthening Community Engagement and Accountability for Primary Healthcare, and Social and Citizen Participation for Primary Healthcare Projects. And what have we done with that? We've been able to guide citizens, especially by building the capacities of CSOs and other community members, especially the WDC, to improve accountability, especially at the PHC performance. Now, when we look at this, the community members are able to provide feedback on the services that they have received. Now, because that enabling environment is there, we're able to use that to make analysis, to engage the facilities. We're also using that to also make advocacy calls, to provide briefs. And this has also supported some of the government interventions to say, look, this is the facility, this facility is not in a good condition, this facility needs additional health workers. There has to be an improvement in service delivery across these facilities. And then lastly, with this evidence that we have had, we have seen like there's actually prioritization by community members. Community members are beginning to say, our voices are important. We want to be part of the conversation. This is how much we can contribute to the facility itself. And this is how much we're also demanding. And overall, we've seen an improvement in health outcomes. We've seen an increase, a surge in PHC utilization following the advocacy and awareness sessions that they have had. We've seen that certain parameters which we were also tracking, such as the RAMPA parameters, we've also seen an improvement in them. And this has translated into improved health outcomes across our implementing facilities. And in the coming weeks, we hope that we're also going to expand past the number of facilities where we're actually implementing in, and this will give us a broader view. So thank you. I know it's a bit noisy on at my back end, but thank you very much. I hope you could hear me when I spoke.
Yes. Thank you so much, Dr. Davidson, for taking our time to respond. Thank you. So if it's okay by you, can I come back to you in about 10 minutes?
Yes, please.
Okay, thank you. Dr. Obi, I'd like you to speak on the Basic Healthcare Provision Fund, please. Especially in terms of accountability and impact, yes.
Yeah, thanks. Just to provide some additional information on the Basic Healthcare Provision Fund. So this fund, for most participants, so that we understand where this is coming from, it's a provision in the 2014 National Health Act, where it says that every Nigerian should have access to a basic minimum package of health services to be funded through the Basic Healthcare Provision Fund. And this Basic Healthcare Provision Fund is a direct, like when you have first line child, similar to UBEC, that's the Universal Basic Education. So it's the 1%, at least the law says at least 1% of the consolidated revenue of the federal government, not the federation. So I know there's a lot of focus on the Basic Healthcare Provision Fund because it's money that is guaranteed. So every year there's a disbursement and it's linked to the income of the federal government. This implementation started around 2018 because that was when it was officially launched, or pretty much, let's say 2019, January, February. That was when it was launched officially under President Buhari. But the point is that I know a lot of citizens have interest in this. So we've had a lot of iterations. So just when the red letter was released last week, so we have what we call the Ministerial Oversight Committee of the Basic Healthcare Provision Fund, where discussions about the program, checking and monitoring its implementation happens, but also discussions or approvals about the allocations. So the point is that we have what we call four gateways. I mean, forget about the word gateways, but it's channels through which the Basic Healthcare Provision Fund is like sent to states for implementing different things. So we have what we call the NPHCD, that's the National Primary Healthcare Development Agency Gateway, which we call the supply side. So the idea is that almost all the primary healthcare centers, from what Premium Times and Budget has shared, primary health centers do not belong to the federal government. It should be the role of the local governments to take care of primary healthcare centers. And of course, local governments are under the state. So you have some work that the state government should play because we have the state primary healthcare development agencies. But the problem with Nigeria over the years is that the primary healthcare centers do not even get allocations from the local government or the state for them to operate. So you go to a primary healthcare center, they require the patients to bring almost everything they need, from cotton wools to methylated spirit or maybe Macintosh for women who are delivering and all, which is not the right thing. So over the years, the primary health centers have been neglected, and that is what the Basic Healthcare Provision Fund is structured to at least fill some gap. So it is supposed to be a catalytic fund, not necessarily a cure-all solutions for our financing of our primary healthcare centers. So I think it's important for citizens to know this because over the years, the state governments and the local governments have not been playing their role. So the federal government's intervention, even though it is there, I mean, it's what everybody's aware of. But the point is that the local government and the state government need to do more because if they were funding primary health care, possibly the BSPF could have been used just to support and consolidate on the gains. So what happens is that through the NPHCDA gateway, there is what it's called direct facility financing. So money is sent to the primary healthcare centers directly for their operations, for them to buy the basic things they need to operate. So it's sent to them. So they originally, or how it is done is that at the beginning of the year, each primary healthcare center, it's supposed to develop what they call like their operational plan or their business plan that itemizes what they need to do. Maybe if they need to do provide some infrastructure or some maybe equipment that they lack and whatever it is. So they have that in their business plan. If they need to hire like ad hoc staff, maybe ad hoc staff to provide services, they can pay maybe stipend through that money. And then from the NHIA, that's the National Health Insurance Scheme. The National Health Insurance Scheme now pays the primary healthcare centers for services they deliver to those who are enrolled in the program. Even though, yes, the law, the National Health Act says that all Nigerians are to be entitled to a basic minimum package of healthcare services. But when you use the equity lens, looking at the fact that we have multidimensionally poor people, poor and vulnerable people across the country, rural areas, and even some of the urban areas. So the idea is, okay, if you are to achieve universal health coverage, it will be progressive. So you start from somewhere. So the government decided to focus on at least the poor and vulnerable people to start from there. So I'm just laying this foundation. We also have the Emergency Treatment Gateway, and then the Nigerian Center for Disease Control, NCDC, also gets some money to support epidemics and all of that. But the point is that there has been a lot of challenges with some aspects of BHPF implementation. So what is important for citizens, I know that Dr. Pate's letter has created a lot of interest, which is good. And I think what's more important is for citizens to find out, so within our localities, which are the PACs that are called BHCPF facilities. So there are, maybe in a ward, we have about 8,000 to 10,000 PACs that are currently implementing BHCPF. So in a local government, you may just have a few. So when you go to check PACs, I work closely with the committee that's the Secretariat of BHCPF. And the fact is that, to be honest, over these last few years, 3, 4, 5 years, PACs that are providing BHCPF have better facilities and quality of services than the other regular PACs around. To be honest, I'm not speaking on behalf of government, but the point is that most PACs that are BHCPF facilities compared to the regular primary healthcare centers within the same locality or the same local government, you will find out that BHCPF facilities are better equipped. They have more healthcare workers. Some of them are volunteers before, but they are being paid through BHCPF. So in a sense, BHCPF has provided more resources to PACs that are designated as BHCPF facilities because the National Health Insurance pays these PACs for the services they provide to the patients that are enrolled under BHCPF. It is called capitation. They pay them capitation. Capitation means if 100 people are enrolled as BHCPF beneficiaries in a primary healthcare center, the National Health Insurance Scheme pays the health facility money for each of these patients, whether they receive services or not. So these facilities have more resources available to them to provide care. But what has happened is that because a lot of citizens are not aware of this, so the chances of corruption or misappropriation of these funds are high. So it is important for citizens to become more engaged in this, know how much. So there is, I'm not the one to provide this information now, but since the budget is pushing for that, maybe through FOI and other, we can confirm how much each facility receives every month. And then we have the health facility committees or the ward development committees that should be doing that monitoring and accountability and transparency on behalf of the citizens. But it's also important that we use platforms or mechanisms like citizen scorecards and all of that to track and know. So citizens have a reason to ask what is happening in those facilities. For instance, in my local government, last year, or was it early this year, I went to the PSC, where I was born in my village in Imo State. I went there, and it's a BSPF facility, and I asked the facility in charge how many people are enrolled in this program, who from my community is benefiting from that. So I, as a citizen, did that because I know about BACPF. I know that funds are going to the facilities and what they are meant for. Thank you. I will just stop here.
Thank you so much, Dr. Felix, for lecturing us on the difference between state PHCs and the PHCs under the Basic Healthcare Provision Fund. That was really, really enlightening. Thank you so much. So I would like to go to your last question, if you can respond to this in about 3 to 5 minutes. So given the declining donor landscape, how can Nigeria strengthen domestic resource mobilization and move towards self-sufficiency in health financing? So I'm asking this basically in respect to health insurance expansion and how it can play as a sustainable domestic financing strategy.
Yeah, thank you so much. So the declining donor landscape, even though it's seen as something negative, but I also see there's also the silver lining, which we should exploit. So the budget, I'm speaking about budget because with my organization, we've also collaborated with them on issues around transparency and ensuring that citizens participate in accountability and all. So if we look at the Nigerian health budget, I'm using health not because it's the same across all sectors. All the monies we allocate, we don't focus on results. So our budget is not performance-based or outcome-based. Like Dr. Maurice Atoki had shared about, performance contract or outcome-based contracts. Our budgets are just allocated, whether it is for capital or recurrent, and we are not looking at any outcome or result. So with donor funding depleting, we may be asking ourselves, or what citizens we should be pushing for is that if 200 million is being allocated to health sector, for instance, we should be asking that 200,000, what health service or what health result or outcome is it going to buy for us? So will it provide how many, maybe antenatal services, how many women are we targeting that the money will provide antenatal services for, or if they are to do CS, whatever it is, or for immunization. So most times we allocate money, it is for this program, we have that budget envelope, but it is not tied to results. Whereas donor funding, I've worked in this sector for a while, if a donor is giving you money, or if a private sector is giving you money, there is a particular result or outcome that money is tied to, whether it is grant or loan or credit, whatever it is, or even equity, there is a result they're expecting. And we've not been doing that in the public sector or our public financial management system. So that is on one side. Then for insurance, certainly, insurance can be a mechanism through which we can fund our health sector. If our monies are, even the current budget for health sector, the way it is, if it is channeled, if maybe 50% of it is channeled through insurance, such that the National Health Insurance Authority or the state health insurance agencies can be given that money to pay for services. So you don't just allocate money to the teaching hospital or general hospital just like that. Let it be that the monies are channeled through insurance so that NHIA can be buying the services. Because when NHIA is buying service from you, then that money, we know that it is buying results and outcomes. So that way we are efficiently using what we have while we push to expand our fiscal space. So if people see that the money coming into through insurance rather than allocating money for just a lot of things that we don't account for. Any money that goes through insurance, you know that you are paying for result. That way, we may be able to even expand our fiscal space and get more money out of what we currently have. While there are other, I will leave that to Dr. Maurice to share how we can also mobilize private investments and equity into the health sector. So it's happening, like she shared about blended financing and all. We could see how the potential of leveraging private financing, like we saw during COVID. We saw how the public sector and private sector partnered closely to mobilize resources to tackle the problems. I think we can do that for the health sector, both the medium and long term. Thank you.
Thank you so much, Dr. Obi. So I'll go next to Dr. Atoki. Welcome back, Dr. Atoki. So as a follow-up to the question, Dr. Obi's response. Yes, I see you, ma. As a follow-up to his response, how can we make health as an investment compelling enough to attract private capital, especially in preventive care and health insurance?
Right, thank you. And kudos to the other panelists for those very elaborate and useful contributions. So let's come back to the private sector and think about private capital. To attract private capital, we must first of all rethink health and reframe it in a lot of, transactional and non-transactional dispositions to ensure that it doesn't continually sound as a social expenditure, but as an economic enabler. Let's recall that healthy populations drive productivity. They reduce business losses and sustain national growth. So investing in health, especially preventive care and insurance, by a lot of yardstick yields measurable economic returns. It's just because the care component of health is very glaring. Of course, it's either you're alive or you're sick or you're, not alive, God forbid. That we seem to completely forget about the enormity of the role in terms of economic returns that health yields. And the key to this is data and evidence. When we quantify the cost of absenteeism, for instance, in corporate setting, for productivity in manufacturing, preventable diseases, it becomes clearer that preventable investments are far cheaper than curative spending. So private capital, as we all agree, and if you were in the shoes of private capital or private investments or private sector, you will know that we respond to value and predictability. So sometimes when they say private sector is very profit-centric, I just, like, what does it even mean? Everybody wants to make profit. You want to earn something above where you are at. It's almost natural. So if we build a clear investment case, for example, employer-based health programs that reduce cost or digital preventive care solutions with scalable demand, then health becomes an investment and investable market. It's not a let's have it because we care for them or it's a social norm, and it's not just a philanthropic cause. It is by far an investable marketplace. And at ABC Health, we emphasize this through and through all of our initiatives and our partnerships. We link health to the outcomes of business outcomes. And that's the change from spending on health to investing in human capital and in economic resilience. Then we're talking about private capital and the attraction of it. So let me stop there. I thank you for that question, for having me.
Thank you so much. Thank you so much, Dr. Atoki, for that very insightful response. So just go to our last question for these discussions before we dive into the question and answers. And I think we have lots of questions waiting for our panelists. So I promise that won't take too long, please. Dr. Davidson, data-driven advocacy is one of budget strengths. Dr. Davidson, are you with me? Sorry.
Yes, I am. I'm here.
Okay, thank you. So I'm going to ask the last question. Sorry, please. Data-driven advocacy is one of budget strengths. What role can evidence and public data play in ensuring that health spending, especially under the Basic Healthcare Provision Fund, actually reaches communities in need?
Thank you so much. I'd already even started throwing some light earlier on
Exactly,
it.
with your
Yes,
second
because
response.
with my second response. So
Mm-mm.
with this basic healthcare provision, and I'm actually very glad that Dr. Felix did a thorough job when he was actually explaining the BHCPF and breaking it down. But evidence itself speaks. And one way we could look at evidence is one, looking at it, does it equate to transparency and accountability? And what do we mean by accountability? Tracking. How are we able to ensure that the right people, especially at the community level, the right stakeholders, especially at the accountability mechanism for CSOs, how are they able to actively see where these monies are allocated to and see how these monies are being utilized? Now, if you look at it, some time back we had requested and we had actually started a process itself where we looked at the over 8,000 PHC facilities. We had requested a list of these facilities and we had looked at how much of these facilities had received their allocations so that we would be able to follow these funds. Now, making these funds visible, as has been clearly stated in the red letter itself, is a prerequisite for accountability. And the second part of it is also looking at how do we link these frontline facilities and their respective service deliveries. The BACPF is mandated by the the BACPF itself focuses on providing packages, minimum packages to community members. Now, when we're looking at these minimum packages that are being offered to these community members, are these PHCs getting the right funding? One. Two, how is it translating to their service delivery? And lastly, how is it looking at the health outcomes? I think in the initial conversation what we're having, I was talking about it's not just the allocation itself. Are the right services being provided? Are the right equipment being available? Do they have the right environment to be able to function optimally? And then how is this looking at the impact and all at the outcomes? And how is it also looking at the impact on the community itself? Now, then lastly, when we're looking at this, we must be able to track service utilization in terms of one, quality and also equity. By equity, we mean that the right people get the right services that they need at that moment. And then lastly, as I was explaining earlier, citizens are in the mix of this. Community members and citizens engagement is key to be able to track this BHCPF fund. Community members have to be part of it. First of all, they need to be aware that this is how much got into the facility. Two, they must be party and they must be part of the annual operating plan at these facilities. The WDC members who are the focal persons, and these WDC members are not an entity on itself. They're actually recognized by the government. They actually part of the community structure itself at the local government level. They have their meetings, they have their engagements, and then pairing together with the CSOs, community members can be able to guide the process of accountability at their primary health care. So looking at all of these community level actors, the local government facility monitoring tools that have been put in place, and then also the citizen and the data itself, because budget itself collects a form of feedback at the facility level that can be utilized at some of these engagements to provide what and to improve accountability itself. So this open data source not only drives the institutional engagement, but it empowers citizens to ask the right questions. It empowers citizens to demand better performance, and then also it also forms as a matrix for us to have a what do you call this? Well, it also forms as a matrix for us to have a comparative analysis. Dr. Felix was talking about BHCPF facilities because they receive this additional funding, are able to provide better service delivery as compared to facilities that do not receive the BHCPF funding. We could also have a statewide analysis to say this XYZ facility in such location received XYZ amount of money, and then let's look at how much they were able to utilize. Let's also look at how much their impact, especially when it comes to health outcomes, have been able to have been reached itself. Now, secondly, we are able to use some of this data that we collect itself to be able to evidence-based conversations. Recently, some months back, we had an institutional stakeholder meeting at the Kaduna level where we were able to demonstrate part of the feedbacks that we had. from our engagements to the government itself, and then also to the relevant stakeholders in the room. And it was quite impressive because people could relate to the information, people could see a trend analysis that was going on, and people could also identify areas of gaps that needed urgent action itself. So thank you, and that's it from me.
Okay. Thank you so much, Dr. Davidson, for your
But
contribution. You have to
just
go?
no, not to go yet,
Okay.
but
Okay.
I would like to just share some last minute thoughts on this BHCPF itself. I think this is something that I do not want to miss is looking at the BHCPF itself and the open data. What will the good practice, what will we look forward to? One, we need to have clear presentation of the data sets. We need to be able to know the disbursement at the facility level. We need to know the PHCs that are involved. We need to know, like Dr. Felix had talked about the different gateways. We also need to know about the state of the PHCs. You had mentioned earlier about revitalization that has been ongoing across the states. And I think over 1,000 PHCs, I think as at the time we were tracking, we had measured up to 1,119 PHCs at that time that we were actively following in terms of the revitalization exercise. And then
Who is
lastly, hi, my name is Biobele. I'm the one who's speaking. I could hear someone at your back end. Nika, can you hear me?
Yes, I can hear you,
Yes.
ma'am.
Then lastly, we need to also look at the measurable outcomes. How is this translating into maternal improvement? How is this translating to reduce maternal mortality? How is this translating into immunization coverage? The second part of it is we need to have a standardized reporting system, a system that cuts across, and not just having a standardized reporting system. We must be able to train the facility personnel. We must be able to train the WDC personnel to be able to have this information and to be able to review this information, and then leveraging on technology itself. We could be able to harvest both the public dashboard in line with dashboards of accountability mechanism that has been created by CSOs. An example is the budget itself, the budget dashboard itself that also tracks the BHCPF, to be able to provide a comparative verification on how these monies are being disbursed. And this will also serve as a second tier validation itself. And lastly, we must always remember that the citizens are in the middle of these conversations. They are the reason why we're having this facility. The citizens must be part of the feedback system. Thank you. I think that's the last thank you I'll have for this this point. Thank you so much, Nika.
Thank you so much, Dr. Davidson. You've said it all. Thank you so much for your contribution. So our time is fast spent already. I'll just go straight to our question and answer, please. I noticed Dr. Felix had actually responded to some of those questions, but for clarity's sake and for others, I'm going to ask a few of them again so you can just throw a little light on them. Dr. Felix, are you with me? Dr. Felix, please, are you?
Yes, I'm here. Sorry, I
Okay,
didn't know I
good.
was muted. Yes. I was also
Okay, good. I
responding to
noticed.
some of the questions.
Yes, I noticed that, but I still want you to just throw light on them. So 1 minute, Dr.
Yeah.
Felix, please. Thank you so much. So I'll just go to the first question from Musbao Amza. So given that, this to Dr. Felix, please. Given that many NGOs and private organizations support health interventions in Nigeria, some with budgets exceeding those of certain state governments, are these entities mandated to join the SWAP, the sector-wide approach, and submit their annual operational plans or budgets for review? Did you get that, please?
Yes, I did. So, like I did mention earlier, so we have the Development Partners Group on Health, which is like all the donors, they work closely with the SWAP office. So especially at the federal level, there is that movement towards ensuring that any program that the donors or the development partners are to implement are to align with the AOP developed at the federal level. So all the development partners, like I said, they signed the compact for health, and they are to align their programs to fit into that. So we have now a harmonized the health sector blueprint, which defines all the activities, all the priority areas, and all. So yes, at the federal level, everybody's aligning. Even though yes, we may not necessarily have like a pooled or a basket fund yet. But the point is that if all the activities are streamlined and then there are no duplications and all, then it makes it a lot easier for resources to be used efficiently. And I think states are also trying to do that. So it's important because in countries like Rwanda or Ethiopia, you don't just come and say, this is what you want to do. When you come in, they show you the plan and then you plug in. You identify where you are going to intervene and then the resources. So you make that resources available. So if you are going to invest $20 million or 10 million, whatever it is, it has to speak to a specific priority need or intervention that the government has defined. So the onus is on us as a government or as a people to make it difficult for donors to just come and do what they want to do. We have to show leadership and direction, and then the donor partners will align. Thank you.
Thank you so much, Dr. Felix. So I have a question here for Dr. Atoki, though she already spoke on this, but I'll still ask so she can probably add 1 or 2 points. Dr. Atoki, beyond, this question is from Rachel Abuja. Beyond philanthropy, what is the single most impactful way the private sector can drive sustainable improvements? These models effectively in Nigeria can drive sustainable improvements for these models to be effective in Nigeria.
I think I mentioned a couple of options along some of the examples that I gave. So I talked about blended finance. I talked about performance-based contracting and public-private partnership, which seems to be the one that we're all used to. The truth of the matter is that we're not harnessing the potential of PPPs enough in a country like Nigeria. It is only through PPPs that we can scale. So all of these solutions, and innovations that sometimes come in many sizes naturally, the way to impact in a scaled, to impact the population that are really vulnerable, that deserves that impact the most in Africa and in Nigeria, actually is by public-private partnerships. So we know that public health is a responsibility of government, and 70% of our health and healthcare is actually, channeled around primary healthcare and the whole of public health generally. And so if we don't pay attention to that aspect of health, understanding that even for the private sector, private institutions, to be able to scale and optimize their potential, there has to be government interactions or tendencies in those kind of transactions. And so for me, it's for us as a country, Nigeria, to leverage, all of the successes we've seen in other sectors. So I had mentioned energy and the utility sector. We've seen a lot of success, successful implementation, performance-based public-private partnerships, where we see service providers being rewarded for measurable outcomes in that sector. So again, I will largely recommend for us to deepen our potential for public-private partnerships and go that route. I hope I answered that question. Over.
Yes, yeah, you did, man. Thank you so much for that. Eminent, please, some very interesting question I would want Dr. Obi to respond to. Okay, I think it's actually deleted. I can't find that particular question again. Okay, Dr. Obi, this is for you. Given the gaps in local government funding and citizen awareness of PHCs, how can civil society and media effectively track the basic healthcare provision fund allocations and ensure that these funds translate into real improvements in health service delivery at the facility level?
Yeah, thank you. So I will share an example from budget because we are talking about CSOs. So there was a case where constituency project for, that the legislators, they usually get money for constituency projects or locations and all. So budget went to this particular community to tell them about this, that the federal government has allocated X amount, millions of naira for either building a school or a primary healthcare center. So initially the communities were not aware. So that tells you that it is critical for CSOs to play a role of informing citizens, to let them know about government's programs and what is due to them, at least from the budget, which is a law. So when they let them know about that, even though there was initial pushback from the legislator and his people, but when they brought this information, showed them in black and white what is in the law and the allocation, the releases. So that was when their eyes opened, and then they started asking questions. And eventually, at the end of the day, because they were aware of the allocations that came to them, they were able to hold that legislator to account, and that project was eventually executed. Unlike in the past where monies are released or allocated for constituency projects, and the monies enter voicemail. So the same for BACPF. So it is the role of civil society and the media to make this information available to the citizens, so that if we know, for instance, somebody had mentioned in the comment I was responding before now. So he said in Bauchi there is a BACPF facility that is next to even like the traditional ruler, and there was no human resources, that's the head personnel in that BACPF facility. And I was trying to say, there's no way a BACPF facility will not have the human resource, because there are specific criteria for a PSC qualifying to provide BACPF services. So there's usually an assessment that the NPHCDA, that's the primary healthcare agency, will do to check that they have the right resources. There is just a basic minimum number of health workers, because to provide BACPF benefit package, you're supposed to have at least the basic minimum number of care workers, whether nurses, midwives, or community health workers, to provide that service. So if a BACPF facility doesn't have that, then it's possible that either they are playing truancy, maybe they are not resuming to provide the care. So that means there's a gap in the work that the health facility committees or the ward development committees are supposed to do. And if citizens go to a health facility and they don't see health workers, then it should be escalated either to the local government health authorities, or find a way to, whether it's in social media or any platform, to make that known. Like the red letter that was released last week, you could see that a lot of citizens are now, who were not aware of BACPF, are now aware that there is a program called BACPF and money goes to those facilities. And now people are asking questions. I received it on my WhatsApp, forwarded so many times. So you could see that making information available to the citizens also helped to strengthen accountability and citizens asking questions about how monies are used. Thank you.
Thank you so much, Dr. Obi. So I'll just take 2 more questions before we end. But this is not a question, this is like an observation. Dr. Atoke, Dr. Atoke, the access to the knowledge hub on your website is passworded. Can you please help? Okay, that is for Dr. Atoke. I think it's great that I mentioned that. One question is what procurement? Okay, Dr. Obi, this question I think is for you. Thank you for the presentation. My question is, what procurement models are to be adopted to improve drug availability in the PHCs? Inadequate drug supplies at the facilities also erode citizens' trust in government-provided health insurance. So the question is, what procurement method are to be adopted to improve drug availabilities in the PHCs? And I mentioned earlier that Premium Times did an investigative report in about 2 or 3 of the states in Nigeria. That actually shows that majority of them do have drugs available. So please respond to that.
Okay, thanks. So even before procurement, so there is the issue about forecasting and making sure that what you need, you place orders for it. So, for instance, so we have what we call logistics and supply chain. And it is important that health facilities know what they need. And then, so at each point, are you replacing what you have already used? So if you go to, for instance, in the private, Dr. Atoki is from the private sector, and she can tell you that supply chain is a key component of any service that the private sector is providing. They make sure that their supply chain system is very strong. In the health sector, maybe because we don't have those efficiencies that private sector has, so we oftentimes we do not necessarily forecast what we need and then constantly check that what we have is enough to provide the services that we are supposed to provide. So I think that's where the gap is. So PSC might just, maybe they are not keeping the right records and ensuring that they are procuring and having, seed stock that, that you are supposed to have like a minimum stock that at any point, if you, for instance, there is failure or delay in delivering what you need, you have sufficient products and commodities to provide the ideal care so the number of patients that come to your facility each month. So you need to make sure that you have the right number, at least basic minimum stock that can provide care, even when there is delay or so you don't necessarily run out of stock, which is the problem. So some facilities have like the drug revolving fund, which they use to procure and all. But as a country, we have the DMAs, that's the drug maintenance or management agencies, who are supposed to stock the commodities and drugs needed at each facility, and then they can use what they call the push or the pull system to ensure that the facilities have enough drugs, medicines, and commodities that they need. I mean, we can discuss about supply chain and logistics management. It's a big topic on its own, but the point is that they need to have the right system to be able to quantify what they need and ensure that what they need, they have the stock and they don't run out of stock for key things. Private sector will never allow such to happen. So some of the inefficiencies we have within our public system, and so there are mechanisms for addressing that, both through funding and making sure that supplies are done when they need to be done, and all of that. Yeah, thank you.
Okay, thank you so much, Dr. Obi. So to the last question now, I think it would be best to respond to this too, the last question. In all honesty, we cannot talk about health financing without keeping to note the importance of the functional and absolute autonomy of the various government levels. The discussion around basic healthcare provision fund is very important, and we very much cannot but appreciate the awareness created around it. But here's my question. How can we go about it in such a way that there is no tracking fatigue? As important as the fund is, it is obviously an overlapping responsibility of the federal government because it is an initiative that should be locally driven, like local government level. So for every tracking, there should be immediate act of holding some individual responsible. So how do we go about tracking this in such a way that process does not come with tiredness and fatigue? Dr. B, please, that's the last question for this session.
Okay, yeah. So thanks. Yes, indeed, I agree that BSCPF shouldn't be a federal level intervention, but it's because of the weakness of the subnational level. We know that the local government, beyond health, local government, in short, the concept of primary health care, the services are even beyond, it's more like an intersectoral or multisectoral thing, covering both nutrition, water and sanitation, the environment, education, and a whole lot. So if at the LGA level, the local government is providing these services, then there wouldn't have been any need for the basic healthcare provision fund. For those who have lived abroad, or like the counties provide all these services that you don't necessarily see the federal government, maybe in US or UK, going to be providing this sort of services or providing money for that to be done. So I think the communities So it calls to question why we are not maybe putting pressures on our governors, because a lot of the money that should go to the local government are managed by the state government. With the autonomy of the LGAs now kind of reaffirmed by the Supreme Court, I think our communities should be pushing for autonomy of the local government so that the services, because the local government is the level of the government or the tier of the government that should provide the social services to the communities, to our citizens. So we need to be more vocal. We need to ensure that currently the local governments still get disbursement from the Federal Allocation Committee. And a couple of times they publish these figures in our newspapers or on the website of the Federal Ministry of Finance or the Budget Office of the Federation. So our citizens should keep our eyes on those allocations. And then if we know how much our local governments receive and our chairman, maybe they pocket what comes to them, then it is a failure of our duties as citizens. Because in a democracy, for a democracy to thrive, citizens' participation, citizens' engagement, citizens asking the right questions make democracies thrive. So for our health sector, especially at the primary healthcare level, to thrive and be strengthened, then the citizens cannot keep quiet. If we see something, let's say something. If we see that things are not working well, we now have the media. Media space has been democratized. So we can take pictures and then push it out there. It can help shame both our local government chairmen and councillors or people who work at the LGA, but also our representatives, whether the state houses of assembly, we have people who represent us there. Federal House of Representatives, as well as our senators. We can push to make sure that they do what they need to do for our people. Thank you. Let me not take so much of our time.
Thank you so much, Dr. Obi, for keeping to the time. And that's the last question for this very important discussion. Please, okay, sorry, please. I'm trying to get my okay, thank you so much. Thank you so much, Dr. Obi, Dr. Atoki, and Dr. Davidson, for your very thoughtful contribution to the panel session. We've learned a lot from the three of you, and I'm sure everyone on this call actually picked one or two from here. So from today's conversation, one thing is clear: ensuring sustainable aid financing in Nigeria will require shared responsibility across government, the private sector, civil society, and the media. So on behalf of Nigeria Health Watch, the Punch newspaper, and Premium Times, I thank you all for joining. Thank the panelists, the audiences, our partners here for joining and making this discussion as insightful as emphatic kind of. Thank you so much. I appreciate it. Please, before you go, would like you to fill a post. A minute. I'm trying to ensure they've posted a link. Okay, 1 minute, please. Please hold on. Okay, thank you all for joining. I can't find the link. There's supposed to be a post. Okay, please, the link is in the, yeah, I can say it now. The link is in the chat box. If you can just check it, and please take the post-event survey, please. Your feedback is highly appreciated. Thank you so much. And bye.
Okay, bye, everyone.
Thank you, and bye.
Thank you.
Everyone.
Bye. Bye.
Bye.
Dr. Taki.
Bye.
Thank you.
Nika.
Bye. you.